Good evening to everyone and welcome to today's session. Mirza, Prem Kumar, Room Singh, Thanaya Sachdeva, Payal, Manish Krishna and many more who are all across the country. Mirza Moin is asking, sir, when will this coronavirus pandemic will end? Whatever. Very good question. I'm also looking forward for the same, doctor. 3 weeks of abstinence, social abstinence, I'm quite sure should make us to cross that incubation and clinical period, maximum incubation period of the corona. And I'm very sure that once more the good days will bloom back from April 15th. But before the good days bloom, where are the bad days? Only it is all in our thought process. One or the other day we all need to prepare for the upcoming NEET PG, FMGE and the USMLE and the MBBS exams. Exams will remain. The challenge to prepare will remain. So that is the reason let us make the best use in the next 21 days. Let us revise around 3,000 questions and do a discussion on the USMLE Step 1 subjects. Anatomy, physiology, biochemistry, micro, pharma, patho, and behavioral science. And these conceptual reviews of these 3,000 questions in the next 200 hours is going to be the basis for you to crack any exam. So consider it as a nature's paid holiday and research yourself to prepare along with Dr. Murli Bharadwaj. Like every day, I bring to you around 50 questions, clinical vignette based questions, USMLE styled questions. You solve the questions, we have a discussion of the concepts. At the end of it, you get inspired to pick up 4 or 5 topics, go back to the online MBBS.com. On the video library, you do the revision. That way, make the best use of your time in this next 3 weeks of forced holiday given by the nature to all of us. Let's make the great beginning, doctor. So, today's quiz is having around 48 questions and every 15 seconds you have a question rolling out. And I want all of you to proactively answer. Thank you so much for 30 of you being present online. And I want to once more introduce to you, doctor, if you go to onlinembbs.com, you have some very good free notes. A free notes PDF is made available for you to download. So every day we will be changing a new notes PDF. So in order to download the PDF, there is a small form where you fill the mobile phone number, email, name and place, and you can be able to download the PDF. So this is a new feature we added into the online MBBS. But otherwise you have all the video library, full-scale grant tests, everything available on the online MBBS.com. So let's make beginning of the today's quiz. Now it is all your show, doctor. Keep punching the answers. Within another 12 minutes, I come back to you and then we are going to have a discussion on these questions for the next couple of hours. So, good evening, everyone, and welcome back. So, 49 questions should give you a very clear challenge that should be able to drive you to take up this quiz. Now, doctor, the plasma levels of the ketoconazole, they are lower than normal after the oral absorption whenever you treat the patient with lansoprazole. Keep punching the answers. What is the main reason for this? Basically, ketoconazole requires an acid environment for its oral absorption. If you happen to give lansoprazole, like Misoprostol, lansoprazole, etc., the acidic environment, acidic milieu in the stomach mucosa that get affected, and that lead to a improper oral absorption of the ketoconazole is what you need to basically appreciate. Now, how do glucocorticoids are going to help in the management of asthma? Basically, they are anti-inflammatory. But at the same time, they immunocompromise the person and can lead to the development of the oral candidiasis, which is the oral thrush, is an adverse effect of administration of the steroids, is what you need to basically remember. Very good to see Pradeep Reddy Sahab being online. Good. So, always Pradeep Reddy increase a lot of important points. So, proton pump inhibitors normally inhibit the cytochrome P50 or CYP. Okay. Now, which drug lowers the intraocular pressure? Latanoprost is one of the anti-glaucoma drugs. Latanoprost is a prostaglandin F2 alpha analog, which is used to lower the intraocular pressure. Now, if you look at the other options, Ergonovine, Atropine, terbutaline, let's have a comment about each of them. Ergonovine causes the smooth muscle contraction in both uterine and vascular smooth muscle, and typically it is used to control the postpartum hemorrhage. Then how about atropine? Atropine raises the intraocular pressure and it will precipitate glaucoma. Then you should know what are all the various ways the intraocular pressure is controlled. Either by decrease of the intraocular aqueous humor production, or by increasing the drainage, or sometimes there is some of the glaucoma drugs have both the actions. So that is very important to remember. Now you have been, there is a drug, typically the response of the drug, if you give mecamylamine versus propranolol versus phenoxybenzamine, the response has been shown. So now the question comes, what is this drug? What is this drug? What is this drug? If nothing is there and on a control, if it is being given, what is the response? If mecamylamine is being given, what is the response? Propranolol, what is the response? And phenoxybenzamine, what is the response? Very good. Ritesh Raja gives a very good compliment to Pradeep Reddy. I am a FMGE student and most of the time I look at the value added comments of Pradeep Reddy. That is the reason we all dearly call Pradeep as Professor Pradeep Reddy. Very good. So always, doctor, the whole purpose of the preparation, coaching or anything is we all come together as a group. We all take up a set of questions. We do a discussion. We revise the concepts. We add few points to each other. And then we go back to the video library to do the preparation with added energy. That is the whole purpose. Whether we go to reading rooms, whether we go to libraries, whether we form a social groups, study groups, or whenever we attend coaching, the whole purpose is Spardhaya Vardhate Vidya. You need to have some amount of the chiseling force between the co-competitors that should give that competitive edge and energy to prepare for the entrance exam. So let's make the great beginning, doctor. So this drug is isoproterenol. Isoproterenol. Now, what is the importance of, how do you know that it is isoproterenol? Because without anything, this is the effect of the drug. The effect of the drug. So, the effects of the drug are changed by the treatment with a beta blocker. Beta blocker like the propranolol. Option C is propranolol. It is not affected by the alpha blocker. Alpha blocker. So that is the reason the most likelihood of it is being isoproterenol, because a alpha blocker could not affect it. Only a beta blocker is able to affect it. So that is the reason it is most likely to be isoproterenol. Now in this context, you should know what are the various catecholamines which are alpha selective, which are beta selective, and etc. etc. We will take up, there is one quick table which says which are more alpha affinity, which has more beta affinity, beta 1 affinity, beta 2 affinity. We are going to have a discussion of the affinity to the alpha beta receptors by the various catecholamines. I'll give you one table in the next question. Now, which drug used in chronic gout causes the serum uric acid levels to come down, same time urinary uric acid levels to increase, urinary values. That means it is able to bring down the serum uric acid by increasing the urinary uric acid excretion. That means it should be a uricosuric drug. Which among this entire list is a uricosuric drug, doctor? Probenecid is a uricosuric drug, is what you need to remember. So whenever the patient is having a chronic gout, the main strategy is to decrease the uric acid formation from purines, either by inhibiting the xanthine oxidase with a drug like allopurinol, or increasing the elimination of the uric acid excretion by giving a uricosuric drug. Probenecid basically blocks the tubular reabsorption of the uric acid, and that is the reason it is a typical gout drug which is uricosuric in nature, is what you need to basically remember. Constipation is unlikely to happen with, obviously, docusate is an example of a stool softener. It won't happen with docusate. Whereas promethazine, loperamide, scopolamine, diphenhydramine, all these are associated with constipation as a associated adverse effect, is what you need to basically remember. Cromolyn sodium, what is the function of it? Cromolyn prevents a antigen-induced degranulation of the mast cells. So the whole problem in the bronchial asthma is their bronchi are having hyperreactivity. At the same time, The inflammatory mediators, that is mast cells, they degranulate and release a lot of bronchoconstricting substances. So that is basically prevented by the chromoline, which is given prophylactically to prevent the bronchial asthma, is what you need to remember. So what are methylxanthines? How do they help an asthma patient? Methylxanthine is theophylline. Theophylline is a bronchodilator because it inhibits the phosphodiesterase. So normally cyclic AMP is being broken down by phosphodiesterase. If you prevent phosphodiesterase, if you inhibit phosphodiesterase, you are preventing cyclic AMP degradation. So a high cyclic AMP will lead to bronchodilation. So that is the reason we use phosphodiesterase inhibitors. Similarly, theophylline also acts on the adenosine receptors, leading to the development of the bronchodilation, is what you have to emphatically remember. Now, a drug A is applied, later A plus B is applied. You can see what is the effect of it on cardiac output, total peripheral resistance, blood pressure, respiratory resistance. Now the question comes, what is this drug A and what is this drug B? So the drug A is terbutaline and the B is phenylephrine. Now let us look into what is the logic behind this question. The drug A is decreasing the total peripheral resistance, and also it is decreasing the blood pressure. The drug A, after you apply drug A, the total peripheral resistance is decreasing, vasodilatation is happening. Also there is a blood pressure also is decreasing, and that is causing a reflex sympathetic discharge. And that reflex sympathetic discharge is making the heart to more inotropically beat, and the cardiac output is increasing. So the vasodilatation is happening, that is causing a fall of BP, that is reflexly causing the cardiac inotropic state to increase, and cardiac output is increasing because of that. So, but there is no direct effect of it on the cardiac output. So, now drug A and B are terbutaline and phenylephrine. So, you can see what's happening if you give terbutaline. Terbutaline is a beta-2 agonistic drug. So once you give terbutaline, a beta-2 agonist, that lead to bronchodilation, and the pressure inside the bronchi will fall down. So that is the reason it is terbutaline. And the drug B is phenylephrine, because it has no effect on the respiratory resistance, but all the remaining things it has got an effect. So that is the reason it is terbutaline and phenylephrine. Now, why is hepatotoxicity? Lohita Agastya, most welcome. Nobody is late nowadays with a lockdown in the home. Only we are in either kitchen or in the garden or around here and there in the home. So, and some of the doctors are on the duty. So, there is a great beautiness of the live online sessions, because anywhere, anytime, affordable, accessible, more importantly, one-to-way communicative with the teacher. If you don't understand, you can always say, hey sir, please repeat. We can't do that in a live face-to-face class. So that is a great beauty part of it. So why is hepatotoxicity due to acetaminophen is greater than the normal in a person who regularly consumes the ethanol? Ethanol induces P450 enzymes. So you should remember, ethanol has mixed effects on the liver metabolism of the drugs. Acetaminophen is mainly metabolized by conjugation reaction, but a minor pathway involves P450, resulting in the formation of reactive metabolites, which are normally inactivated by the glutathione system. Suppose if the person is taking chronically more than average amount of ethanol, if it is only 2 pecks of whiskey or brandy, every day there are a good number of people who take every day 60 plus 60, 120 ml of whiskey. Some people take every day 60 ml of alcohol. So, if they are taking more than the average amount of ethanol, then that induces the formation of P450 isozyme that converts more and more of this acetaminophen into a reactive metabolite. And because of this reactive metabolite, which is very toxic in nature, that makes the overall hepatotoxicity worsen in the people who are taking the alcohol more often. When they take acetaminophen, paracetamol, then they end up in hepatotoxicity is what you need to remember. Now, cancer patients are treated with 6-mercaptopurine. They require a dosage adjustment if they are concurrently treated with for which of the following. So you need to know that if you are treating with probenecid, a uricosuric drug like probenecid, the chronic gout, in them if you happen to give 6-mercaptopurine, 6-mercaptopurine is a substrate for xanthine oxidase. Yes, not probenecid, but allopurinol. If you are treating the patients with allopurinol, allopurinol is a xanthine oxidase. Mercaptopurine required to be metabolized by the xanthine oxidase. So that is the reason what will happen. The 6-mercaptopurine toxicity will increase. If the patient is receiving the allopurinol and you have inhibited the xanthine oxidase, then the 6-mercaptopurine metabolism get affected and that lead to the development of the toxicity is what you need to remember. So what is the drug of choice? Especially to treat the peptic ulcer caused by NSAIDs. You all know very well, NSAIDs lead to decreased prostaglandin production. Decreased prostaglandin production, and that will decrease the blood flow to the stomach, and that is responsible for the NSAID-induced ulcers. So, giving misoprostol, you are once more giving a prostaglandin. It is a prostaglandin analog. It is especially indicated for the specific use in the NSAID-induced ulcers is what you have to emphatically remember. Now, Lolita is asking, sir, what about in bone cancer? I could not follow, doctor. In bone cancer, what? Can you explain it more? What's the question? Now, sleeping pills, which are used over the counter, they can lead to convulsions. What are those sleeping pills which are used over the counter and that can lead to convulsions? Diphenhydramine typically are the sleeping pills over the counter that lead to convulsions. So very commonly in a lot of cough syrups, etc., you have this diphenhydramine, and in certain vulnerable population it can lead to development of convulsions, is what you need to remember. Which glucocorticoid has a lot of mineralocorticoid activity and it can lead to the development of sodium and water retention, is the examiner's question. So you should know each glucocorticoid's mineralocorticoid activity emphatically for the tomorrow's exam. It is the cortisol out of all this. Now let us look into it. Cortisol has glucocorticoid activity 1 and mineralocorticoid activity 1. Then prednisolone, if you take prednisolone is 4 times more powerful than the glucocorticoid, cortisol. Dexamethasone, betamethasone, they are 30 times more powerful as a glucocorticoid than the cortisol. Cortisol is the fundamental glucocorticoid, hydrocortisone. It is equivalent to 1 unit of glucocorticoid, 1 unit of mineralocorticoid. It does have mineralocorticoid activity. Aldosterone has no glucocorticoid activity at all. Fludrocortisone is the most powerful mineralocorticoid. 125 is the potency, mineralocorticoid potency of fludrocortisone. Then if you take aldosterone, its mineralocorticoid efficacy is almost 80 times that of cortisol. And prednisolone is 0.8 is the mineralocorticoid capability. So mainly you should know this very important relative potencies, glucocorticoid and mineralocorticoid potency is what you have to basically remember, doctor. Now, with regard to the antithrombotic medication during pregnancy, what is a true statement? So, warfarin has a teratogenic effect. That is the reason you have to replace it with heparin. Replace it with heparin during pregnancy, because it can lead to dysmorphogenesis. And if you use heparin for a long period of time, what is the important adverse effect, doctor? It can lead to the development of thrombocytopenia. Thrombocytopenia. A drug which is used in the treatment of rheumatoid arthritis that slows the progression of the disease and causes the side effects including giddiness, tinnitus, blurred vision, pruritus, corneal deposits, and slight retinal pigmentation. After telling all this, you should be in a position to jump and answer. Very good. Pradeep Reddy adds a very good mnemonic for you to remember. The P in heparin, the P in propyl thiouracil are safe in P, that is pregnancy. Whatever. Very good. Very good. So, what is your answer, doctor? Hydroxychloroquine can lead to giddiness, tinnitus, blurred vision, pruritus, corneal deposits, and slight retinal pigmentation. One of my patients today gave me a call. Nowadays, as clinicians, to go to the OPD also is challenging. So she was asking, everywhere in the news they are saying hydroxychloroquine sulfate is very good protection against COVID virus. Can I use it, doctor? So I told her in the teleconsultation that you can do that if you are ready to risk for giddiness, tinnitus, blurred vision, pruritus, corneal deposits, and retinal pigmentation. Stay home, enjoy a good time, watch TV instead of becoming a victim of hydroxychloroquine for no reason. Yes? So that's the point, doctor. So, yeah. So, ocular toxicity is characteristic of the chloroquine. The corneal deposits are reversible, but retinal pigmentation can ultimately lead to the development of the blindness, is what you need to remember. So, what are the various disease-modifying agents in the rheumatoid arthritis, doctor? Gold salts, methotrexate, etanercept, and they are all the various drugs which are used in as the DMARDs. Now, doctor, warfarin. What is a true statement about warfarin? Warfarin typically causes vitamin K dependent clotting factors to come down. Now, in this context, you need to know a little bit about the vitamin K and the story of warfarin. Yes. Now, what is the story of warfarin? So, what are the various vitamin K dependent factors, doctor? 2, 7, 9, 10. These are all vitamin K dependent. At the same time, protein C, protein S. These are prothrombotic, these are antithrombotic. But both of them are dependent on vitamin K only. Vitamin K only. So if you happen to give vitamin K antagonist like warfarin, the first factor to fall, that is the shortest half-life, is not for the prothrombotic factors, rather for the antithrombotic factors. So the protein C, protein S will fall down. Normally they prevent thrombus. If they fall down, that leads to thrombus. So though you are giving warfarin, a vitamin K antagonist, as a antithrombotic, the initial tendency caused by that is more of prothrombotic tendency. Then out of 2, 7, 9, 10, the first is 7 will fall. 7 signifies PT. That is the reason warfarin, whenever you are giving, you monitor it by monitoring the INR, reflective of PT, because PT is dependent on the factor 7. 7 has the shortest half-life. So that is the reason early vitamin K deficiency, or whenever you give the warfarin, you follow the PT, which is reflected by the factor 7. But even before 2, 7, 9, 10 fall, the first to fall are the protein C and protein S. Because of that, initially there is a prothrombotic state. So what is a very important clinical dictum, doctor? Whenever you start warfarin, you have to add heparin. You have to add heparin initially. For a period of about, you need to add heparin for initial 3 to 4 days. After that, you can continue the warfarin alone. Otherwise, if you only give warfarin, if you use only warfarin, then this prothrombotic tendency initially will lead to small clots formed under the vessels going to the skin and lead to development of the skin necrosis. That is what you have to remember. Now, doctor, what drug is useful for ulcers, but it will increase the risk of bleeding if you give to a person who is using warfarin? It is cimetidine. Cimetidine is an inhibitor of the hepatic cytochrome P450, which normally metabolizes the warfarin. If the P450 is inhibited, warfarin cannot be metabolized, and that leads to excessive bleeding diathesis. So there are many other drugs whose toxicity is increased if you happen to give cimetidine, which is a P450 inhibitor. What are they? Beta blockers, isoniazid, procainamide, metronidazole, tricyclic antidepressants, phenytoin. All their metabolism is affected. If you give a P450 inhibitor like cimetidine, is what you have to emphatically remember. Now, what are the potential drug interactions in a patient receiving warfarin? If you use antibacterial sulfonamide, it can enhance the effect of the warfarin. What is the reason for that? Warfarin binds extensively but very weakly to the plasma proteins. And any other drug which can strongly bind with the protein, like salicylates, chloral hydrate, phenytoin, sulfenpyrazone, sulfonamides, any of them can displace the warfarin from binding to the plasma protein, and the free warfarin increases, and that leads to the development of the toxicity, is what you need to remember. If you give bile acid sequestrants, cholesterol, etc., they bind with an acidic drug like warfarin. So it will decrease the gastrointestinal absorption. That makes warfarin ineffective. The warfarin becomes ineffective because of decreased absorption if you happen to use bile acid sequestrant, which binds with the acidic drug like warfarin. That's what you need to remember. Now, what is the drug that blocks the synthesis of leukotrienes? Pradeep is adding a point. Bile acid resins can make loss of the vitamin A, D, E, K. As K is lost, it can lead to an increased prothrombin time also. There are multiple possibilities, but the bile acid resins always do not lead to a fat malabsorption or a fat dependent vitamin K unless you use them for a long period of time, right? So most important thing that happens is drugs like warfarin, their absorption get affected. So that is for sure. So doctor, which drug blocks the production of leukotriene? Gileutin. It blocks the enzyme 5-lipoxygenase and prevents the formation of the leukotrienes, as all of you know very well. Good to see Manish, Manisha, and many more who are all online. Guys, please remember, on the online MBBS.com, we have added one form where you can enter your mobile phone number, email, name, place, and that gives you a chance to download the PDF. Every day we will be keeping one new PDF, a free handwritten notes, etc., etc. Fundamentally, it is a marketing strategy in order to get your numbers, so we call you and then we sell you the video library online subscription. yes, but at the same time, it will also give you an opportunity to get at the most discounted price sometimes when our online video library sales are on a little lower side of the state, then we try to give a huge discounts and then make it available. So there is a reason. Take every opportunity to also please popularize this online MBBS.com video library to all your friends in the WhatsApp group, Facebook groups, etc. Our students are our best brand ambassadors across the world. Now, doctor, which compound is most likely to block the ADP receptors and lead to prevention of the platelet aggregation and works like an antiplatelet agent? Clopidogrel. The platelet aggregation is stimulated by ADP, thromboxane A2, fibrin, serotonin. Clopidogrel, ticlopidin, they all block the ADP receptors and prevent the platelet activation. Similarly, endothelial cells produce prostacyclin, and that inhibits the platelet aggregation by stimulating the prostaglandin I2 receptors. Similarly, how does aspirin function? Aspirin inhibits the production of the thromboxane A2. A2 is what you need to remember. Finally, what is apixaban? Apixaban is a monoclonal antibody. It goes and attacks 2B3A receptor and it inhibits aggregation of the platelets. So there are the various antiplatelet agents, doctor. You need to mentally register as to how these various antiplatelet agents basically function. One of the favorite question in USMLE and also in any licensing exam that you go for. Now, the drug of choice for temporary maintenance of the patent ductus arteriosus. What is it? PDA is kept patent by prostaglandin. So PPP, PDA is kept patent by the prostaglandin. So alprostadil is that prostaglandin among this, which is typically used to maintain the patency of the PDA, is what you need to remember. Then ipoprostenol, it is also a prostaglandin, but it is a prostacyclin analog. And where do we use ipoprostenol? Ipoprostenol is used in the primary pulmonary hypertension, is what you should remember. What is the primary advantage of the enoxaparin compared to heparin? Enoxaparin mainly has a longer half-life. Enoxaparin is a low molecular weight heparin. It is smaller and has a longer half-life compared to heparin. But just like heparin, it is also a heparin, but a low molecular weight heparin. It also can lead to thrombocytopenia, which is a known adverse effect of the heparin. It can lead to the tendency of bleeding. That is what you need to appreciate. So quickly, doctor, you should know the classification of the various anticoagulants. Anticoagulants can be parenteral or they can be oral. Parenteral can be indirect or a direct thrombin inhibitor. So it can be a direct thrombin inhibitor or it can inhibit factor 10A. So what is indirectly acting? Heparin, because heparin makes antithrombin to get activated activated antithrombin in turn will go and inhibit the thrombin. So it is not a direct effect, it is an indirect effect it is having. Fundaparinux, also like a low molecular weight heparin, is an indirect inhibitor. Then the direct and parenterally used thrombin inhibitors, bivalirudin or gatroban, are typically the thrombin inhibitors. Then factor 10A, otamixaban, is an inhibitor of factor 10A, is what you should remember. Then orally given. Orally you have direct thrombin inhibitor. Dabigatran is a direct thrombin inhibitor, and you have factor 10A inhibitors like rivaroxaban, apixaban and edoxaban is what you have to ultimately remember, doctor. So if you look at the oral anticoagulants, there can be coumarin derivatives like warfarin and acinocoumaral, also called acetrom. Then you have direct thrombin inhibitor like dabigatran is a orally taken direct thrombin inhibitor. And direct factor 10A inhibitors, rivaroxaban, apixaban, they are basically direct factor 10A inhibitors is what you should remember. Now, with regard to aspirin, what is a true statement, doc? Aspirin overdose, salicylate intoxication. You have to do alkalinization of the urine to get rid of the salicylate from the body. Alkalinization of the urine should be done. So, salicylate at toxic doses follows a zero order elimination kinetics, very slow elimination. Similarly, even phenytoin at high therapeutic doses, zero order elimination. And ethanol at all the doses, zero order elimination. That's what you should remember. The enzymes that metabolize the salicylates, they become saturated at high plasma level, and that lead to a constant rate of metabolism and a zero order kinetics. Then another important point that you need to know is aspirin is a weak acid. If you do urinary alkalinization, a weak acid will become ionized. A ionized molecule cannot be reabsorbed. So there is a decreased tubular reabsorption. That will make it to be lost into urine. So renal elimination will happen. Increased renal elimination. And what is the antidote to the acetaminophen, doctor? N-acetylcysteine is the antidote of acetaminophen. Now, parenteral administration of alteplase. I always advise you all, doctor, be part of our Telegram group, be part of our WhatsApp study group. Also register yourself on the onlinembbs.com. So before we start the session, sometimes late night we start at 10 p.m., sometimes we start at early morning 5 o'clock. You should apologize. You have a physician, medical teacher. So that is the reason. Taking care of patients is one responsibility, and to teach is a natural passion we have. So I try my best to strike a balance between the two. So sometimes it's difficult to stick to exactly 6 p.m. every day. So if you are part of our Telegram group, our WhatsApp group, before we start the session, we will send you a feeler, a line of message so that you can be able to participate. Then one more beauty part of online MBBS.com video library is all these PowerPoint slides are made available in the online MBBS.com. And this video will be removed from the YouTube after the discussion and archived into online MBBS.com video library. So that way, if you go back to online MBBS, you have all the high yield topics, 700 video lectures covering 650 high yield topics here. You have 30,000 heart MCQs, 3,000 video lectures here. You have got the mock tests available. Similarly, all these USMLE styled questions that we are discussing, they're all available, made available even for the undergraduate MBBS exam. Theory concepts, first year, second year, final year, they're all made available. And you also have the USMLE Step 1 coaching. Now all these modules are going into there. So you also get an access to it. And every Sunday morning, 9 to evening 5 p.m., we have got a full day discussion of the medicine, surgery, gynocs, orthopedics, pediatrics in about 18 Sundays, morning to evening. So all those discussions will be made available in here. So YouTube is mainly used as a free live broadcasting tool because it is very costly to have a live streaming one, and no live streaming tool or software is as powerful as YouTube. So YouTube, you get Dr. Murli, all yours, freely, but at the same time, we archive all this video library into the online MBBS.com. So that's the reason. Enjoy the free as it is, but for the revision, you have thousands of video lectures, PowerPoints, MCQs, quizzes, mock tests, everything is made available for a throwaway price. Whatever the price you pay, because if one student joins or 10,000 students join, it is one and same for us into the online video library. So doctor, parenteral administration of alteplase, it can lead to bleeding, but that can be reversed with aminocaproic acid, epsilon aminocaproic acid, which is a fibrinolytic agent. So this leads to fibrinolysis, your alteplase, but this is anti-fibrinolytic agent. Epsilon aminocaproic acid is what you need to remember. So how does alteplase function? It activates plasminogen, causes formation of the plasmin, and it is similar to streptokinase, but the only advantage of alteplase is it only goes and binds with the fibrin, which is a part of a clot, not the free fibrin. So it is very clot specific in nature. So the bleeding tendency will be lesser. Once more, alteplase, reteplase, tenecteplase. I leave the literature for you to know the differences, which is more immunogenic. None of them are immunogenic, unlike streptokinase. All of them are plasminogen activators. Plasminogen activators basically. Fibrin specificity is highest for tenecteplase, followed by alteplase. Plasma half-life is very short for the alteplase comparatively. So you give 15 milligram bolus plus 90-minute infusion up to 85 milligrams if it is alteplase. And plasminogen can become resistant, but the resistance is low with alteplase and retaplase. So these are few facts about alteplase, retaplase and tenecteplase. But out of all this, alteplase is popular because it is a recombinant DNA technology with which it has been formed, is what you need to remember. Now, which is a side effect of sulfonylurea? Sulfonylureas typically release the insulin from the pancreas. So that is the reason they can lead to hypoglycemia. Hypoglycemia can lead to development of confusion. So what are the adverse reactions whenever you are using the sulfonylureas, doctor? Hypoglycemia. Because they make the insulin to get released, it can lead to weight gain, almost 1 to 3 kilos. Nausea, vomiting, they can lead to cholestatic jaundice, a granulocytosis, aplastic and hemolytic anemia, and hypersensitivity. So where is sulfonylurea contraindicated? Pregnancy, no sulfonylurea. Lactation, no sulfonylurea. Renal and hepatic impairment, no sulfonylurea. So that is what you have to remember. Now, which is a medication which is used to induce the ovulation? Clomiphene citrate. Which diabetic drug inhibits the intestinal absorption of the carbohydrates? Acaribose, similarly oglibose, they are all fundamentally what, doctor? They are the inhibitors of the alpha glucosidase in the brush border of the small intestine. So they decrease the absorption of the carbohydrate. But what is the problem whenever you use acaribose or oglibose? All the carbohydrate remained in the gut. It will undergo fermentation, release gases. Flatulence is a important effect of drugs like acaribose, is what you need to remember. So, with regard to hyperthyroidism, propyl thiouracil peripherally, how does it act like an antithyroid drug? It prevents the conversion of the T4 into T3, which is the functional form. That is the specialty of propyl thiouracil. At high doses, propyl thiouracil acts rapidly and inhibits deiodinase, preventing the conversion of T4 to T3. And even iodide is used in hyperthyroidism to manage hyperthyroidism, but the effect of it is very temporary because the thyroid gland will escape the action of the radioiodine induced inhibition of the thyroid production, thyroxine production within a week or two. So that's the point. Now, which is the drug which is used to inhibit severe secretory diarrhea of the hormone secreting tumors of the pancreas and the GI tract, and also used in the treatment of acromegaly? Octreotide. Octreotide is a somatostatin analog. It is used for the management of the secretory diarrhea classically, and also for the management of the acromegaly, which is an insulin secretagogue. Obviously, a sulfonylurea like glipizide, gliclazide, glibenclamide. So you should be quite sure, at least at the end of medical school, you should know how to treat thyroid, diabetes, hypertension, infections. That's a minimum expectation after passing out of medical school. Now, doc, what is the main side effect? I mean, one of the chemotherapeutic agents here, main side effect is nephrotoxicity instead of bone marrow suppression. It is cisplatin. So where do you use cisplatin, doctor? Cisplatin is used for testicular cancer, ovarian cancer, lung cancer, esophagus cancer, gastric cancer. Cisplatin, platinum derivatives lead to emesis, nephrotoxicity, peripheral neuropathy, ototoxicity. They are the important side effects of the cisplatin is what you need to remember. A patient with type 2 diabetes, which a drug mimics the action of incretin and increase the glucose dependent insulin secretion. Very important. Whenever you have hyperglycemia will go to your pancreas and it will tell, hey pancreas, I am high. Time for you to produce the insulin. Then pancreas will say, oh, this glucose is very high. Time for me to produce insulin. But this pancreas is like a rabbit without hearing. So somebody should make the pancreas become sensitive. So it is the incretins which will make the pancreas become sensitive to the hyperglycemia and lead to release of the insulin. So exenatide mimics the action of the incretin, and whenever hyperglycemia is there, it makes the insulin production to increase. That is exenatide. So exenatide is also called glucagon-like peptide 1 analog. Glucagon-like peptide 1 is an incretin which is released from the small intestine, which will increase the glucose-dependent insulin secretion. Now, what is the advantage of this? Even sulfonylureas are going to the pancreas and making it to release the insulin. And your exenatide-like drugs, which are incretins, are also doing the same. But what is the difference? Exenatide is an incretin. Incretin will make pancreas to release insulin only if there is hyperglycemia. Whereas your sulfonylureas, they go to the pancreas, make it to release the insulin even if there is no hyperglycemia. So, what is the effect of that? Sometimes if you write a sulfonylurea to the patient is supposed to take the sulfonylurea tablet. Within half an hour he is supposed to take his breakfast. But he forgot to take the breakfast after taking the tablet. He went reading the newspaper, and then he got into hypoglycemic attack. So if there is any delay to take food, they go into hypoglycemia if you give sulfonylurea. Whereas that is not the problem with exenatide. Even exenatide will also cause the release of insulin by the pancreas. But only if there is a hyperglycemia, only after the patient eats the food. After eating food, only when hyperglycemia develops, then only pancreas will release the insulin. That is the reason hypoglycemic episodes are not a problem with exenatide, but a problem with the sulfonylureas. Sulfonylureas is what you need to understand. Which of these agents is protective against the toxicity of doxorubicin? Dexamethasone, dexamethasone, dexamethasone. It is an iron chelating agent that prevents the formation of the free radicals, which are responsible for the cardiotoxicity, is what you need to remember. Very good. Our Professor Pradeep adds a very good point. Rose goes with love. Isliye, that is the reason. Rosaglitazone will go with love. Love means losing heart. Super, super. Right? So before you give pioglitazone, you should look whether this patient is vulnerable to go into fluid retention and develop congestive heart failure. So that is the most important caveat before you give pioglitazone. Thiazolidinedione is what you need to remember. Very good, very good. So that is the great advantage if you are attending online MBBS.com. Live online sessions, doctor, you have your own classmates who add a lot of value added points. That is how a preparation should be. And the most beautiful things in the world are all free. Many times, if you pay for love, you don't get love. You pay a lot of money for health, get a CT, get a MRI, get many investigations. A lot of times patients go to annual health checkup just because it comes, they are afraid. Because they have money, they think they should not get affected. So, but what happens is, a lot of times, money does not give real happiness, but most beautiful things in the world you get with free. Even online MBBS YouTube live sessions are free, doctor. So please tell also your classmates. Almost every day we have a live interactive session across the year until I am alive, right? So please join. But if you wanted a revision, yes, you are not going to forget onlinembbs.com. Today only you go register yourself and then call our helpline to become part of this thousands of video lectures which are waiting for you to do the revision. Now, doc, what is the drug of choice to treat adrenal glucocorticoid-induced osteoporosis? Alendronate. Alendronate is the drug of choice to prevent osteoporosis. And what is an important precaution with alendronate? It can lead to reflux esophagitis. Reflux esophagitis. So, very important point. Long-term pioglitazone is having a risk of bladder cancer, which you have to be careful. So that's the reason if the patient is very young, you don't give pioglitazone because long-term you can't go with pioglitazone. Alendronate can lead to reflux esophagitis. After biphosphonate is being taken by the patient, you need to advise him to be in the erect posture for about a couple of hours. Activation of the beta-2 receptors. It leads to a fall of blood pressure because beta-2 receptors lead to smooth muscle relaxation. They lead to smooth muscle relaxation, the bronchi, so that lead to bronchodilation. They lead to smooth muscle relaxation in vessels and that lead to vasodilation. That is what you need to remember. Resistance to which anti-cancer drug is associated with increased production of dihydrofolate reductase. Methotrexate. Methotrexate is widely used even in rheumatoid arthritis. It inhibits the enzyme dihydrofolate reductase. so that it decreases the synthesis of tetrahydrofolate. Dihydrofolate to tetrahydrofolate conversion is prevented. And tetrahydrofolate is required for the DNA production, so DNA synthesis is decreased. But cancer cells become intelligent. They upregulate their dihydrofolate receptors, reductase levels, not receptors, reductase, enzyme levels. And that's how they overcome the inhibition caused by the methotrexate. So that is a point you need to appreciate. Giving finasteride decreases the production of what? You all know finasteride is a 5-alpha reductase inhibitor which converts testosterone into dihydrotestosterone. So dihydrotestosterone levels typically fall down is what you need to remember. What is the mechanism of action of botulinum toxin? Botulinum prevents the release of the acetylcholine. That's how it leads to development of paralysis. At the neuromuscular junction, if the acetylcholine is not being released by the synaptic vesicles, then the muscle contraction doesn't happen. That's how the botulinum toxin leads to paralysis, by preventing the release of the acetylcholine. Which is the drug that inhibits polymerization of the microtubules. Any Vinca alkaloid will do that. But which Vinca alkaloid lead to bone marrow suppression? Which Vinca alkaloid lead to CNS toxicity? Vincristin, C for Cristin, C for CNS toxicity. Vinblastin, B for blastin, B is bone marrow suppression. That is what you need to remember. Now, neurogenic diabetes insipidus means what? And nephrogenic diabetes insipidus means what? First of all, any diabetes insipidus means decreased ADH. ADH is produced by the posterior pituitary, which is also called neurohypophysis. And the pituitary is called adenohypophysis. So if the production of ADH by the neurohypophysis is affected, that's called central or neurogenic diabetes insipidus. But if the collecting duct on which ADH acts, leading to opening of the aquaporin channels, if there is any receptor level resistance, that is called nephrogenic. So how do you differentiate? By giving desmopressin. Desmopressin is nothing but a synthetic ADH. If you give the synthetic ADH, if the symptoms improve, what are the symptoms of diabetes insipidus? There is a polyuria. Polyuria. Why polyuria? Because in the kidney, in the collecting duct, the descending limb, ascending limb and collecting duct, if the aquaporin channels, ADH will make them open and reabsorb the water and prevent diuresis. But if the ADH is not available, what will happen, doctor? There's nobody to prevent, the prevention of diuresis is no more there. So that leads to development of diuresis. I think my video is stuck up, doctor. So doc, so you should remember that if you give desmopressin, if the problem is decreased production by the neurohypophysis, it will improve. But the problem is that the receptor level resistance, even after you give desmopressin, it won't improve. That is a point you need to remember. Pradeep rightly points a beautiful point. Amiloride is given in lithium-induced nephrogenic diabetes insipidus. Absolutely. Normally, nephrogenic diabetes insipidus, how do you treat? You treat it by giving thiazides. Except in case induced by lithium, amiloride is preferred. Because thiazides increase the lithium levels, leading to lithium toxicity. Lithium toxicity. Now comes a beautiful point. Why do you give thiazides in nephrogenic diabetes insipidus? This is one important point that you should emphatically understand, doctor. See, what is the big paradox? We are talking about, I'm going to drive on a very important fundamental point. See, this is glomerulus, doctor. Then you have descending limb of loop of Henle, ascending limb of loop of Henle, collecting duct, and on this, who is acting? ADH is acting, opening the aquaporin channels, and that is causing the water reabsorption to occur. If the ADH is unable to act on the receptor, the water reabsorption doesn't occur and it will be lost, and that lead to development of diuresis, full urine. So diabetes insipidus is what? It is fundamentally a diuretic state. Then what is thiazide? Thiazide is also a diuretic. Oh my God. Why do we give a thiazide like diuretic to treat a condition which itself is diuretic? That is the question. There is a logic for that. So where is water getting reabsorbed under the influence of ADH? In the distal tubule, in the collecting duct. But if you look at the proximal tubule, 80% of the water is reabsorbed in the proximal convoluted tubule only. 20% only is reabsorbed in the collecting duct under the influence of ADH. So if the ADH is not there, still this 80% is happening, but 20% is not happening. Reabsorption is not happening. That is leading to diuresis. But this proximal convoluted tubule has a very special property. It is like the wonderful mother. There is a saying in very common saying. A ant-like mother is more powerful than a elephant-like father. A ant-like mother is more powerful than the elephant-like father to feed the children. Right? So if the father is alcoholic, drunkard, vagabond, not taking care of the family, it is like a situation like distal convoluted tubule is not working. Collecting duct is not working in diabetes insipidus. It is a situation like that. So what should mother do? She need to work as a teacher, as a nurse, or some job she need to do, ultimately to feed the children. So this mother called proximal convoluted tubule, whenever the distal convoluted tubule and the collecting duct is not working because of the absence of the ADH and the water is getting lost, this proximal tubule can wake up and do increased reabsorption, all 100%. It only can reabsorb. Proximal convoluted tubule only can wake up from sleep and reabsorb all 100% of the water because the distal convoluted tubule is not working because of the absence of the ADH. But somebody should wake up the proximal convoluted tubule and tell, hey, proximal convoluted tubule, Your distal convoluted tubule collecting duct is not working, all water is lost into urine. Somebody should wake it up. Who will wake it up? Any fall of glomerular filtration rate will be sensed by the proximal convoluted tubule so that its absorption of water will increase. So how can you decrease the glomerular filtration rate? Give a powerful diuretic like thiazide. A thiazide will act on the distal tubule and make a significant of the volume of the fluid go away. That will decrease the plasma volume and that decrease the GFR, and that will wake up the proximal convoluted tubule and make it to reabsorb all the water. From 80% it will reabsorb all 100%. So that whether the distal convoluted tubule and collecting duct are working or not, all water reabsorption is over in the proximal convoluted tubule only. That is the reason we give thiazides. Though thiazide is a diuretic, though the diabetes insipidus per se is diuretic state, still we give the diuretic in a diuretic state like diabetes insipidus. That is what you need to appreciate. Got it? Did everybody get it? Good, doctor. Good, good. Now, once more our graph-based question has come. Now, this time, you have a control mecamylamine, propranolol, beta blocker, phenoxybenzamine, alpha blocker. So what is the effect of this drug? What is this drug and what is the influence of the various things? This drug might have been norepinephrine. So you should remember, doctor, phenylephrine, predominantly alpha receptor agonist, alpha 1 agonist. Alpha 1 receptors will lead to vasoconstriction. So phenylephrine also lead to significant vasoconstriction, lot of vasoconstriction, and its effect on beta is very little compared to alpha 1. Clonidine, it is a agonist on alpha 2. Alpha 2 is there in the presynaptic receptors in the central nervous system. Any alpha 2 agonism will decrease the sympathetic outflow so that the blood pressure will come down. That's the reason antihypertensives like clonidine, they are all alpha 2 agonists predominantly more than alpha 1. You have mixed alpha and beta, norepinephrine and epinephrine. But what is the difference? Alpha 1 is equal to alpha 2 in both norepinephrine and epinephrine. But beta 1 is significantly more than the beta 2 if it is norepinephrine. But beta 1 is equal to beta 2 if it is epinephrine. Beta 1 will act on the heart and lead to tachycardia. Beta 2 agonism will lead to vasodilatation and lead to decrease of the blood pressure, which is the typical nature of epinephrine. If you give epinephrine, alpha 1 stimulation raises BP. Beta 2 stimulation decreases the BP. But overall, mean blood pressure will increase but not that much. It will not increase very significantly because beta 2 stimulation, agonism by the epinephrine is leading to vasodilatation. Then what are beta agonists? Dobutamine, isoproterenol, albuterol, terbutaline, ritodrine, they're all beta agonists. But albuterol, terbutaline, ritodrine, they're all beta 2. Beta 2 is there in the smooth muscle of the blood vessels and the bronchi. They are more significant on the beta 2 more than beta 1. Isoproterenol is beta 1 is equal to beta 2 more than the alpha. Whereas epinephrine, norepinephrine, epinephrine is beta 1 equal to beta 2, alpha 1 equal to alpha 2. Then coming to dobutamine. Dobutamine significantly more on the beta 1 than on the beta 2. Since it acts on beta 1, It will raise the heart. Then you have dopamine agonists like dopamine phenoldiazepam. Dopamine D1 is equal to D2, more than the beta, more than the alpha. So you should know these fundamental table very clearly. Relative receptor affinity of the various catecholamines is the favorite question of the examiner. All USMLE pharmacology questions which are graph based, the fundamental basis is this very important illustration. Now if you take this drug R, what is the effect of it? The effect of the drug R changed by either alpha or beta blocker, so drug R must have an affinity at both the receptors. So that is the reason mixed alpha and beta is a property of both norepinephrine and epinephrine. But in this case it is norepinephrine but not epinephrine. Why? Because if it were to be epinephrine, let us say if it were to be epinephrine alpha 1 is equal to alpha 2, beta 1 is equal to beta 2. If it were to be epinephrine, if you happen to use an alpha blocker, what is the effect of alpha blocker? Alpha is blocked, beta 2 is unopposed, beta 2 lead to vasodilation, and that lead to suddenly hypotension. What is that called? Epinephrine reversal. Normally epinephrine lead to both alpha 1, beta 2, both of them stimulated, but alpha 1 more than the beta 2. That's the reason the net effect is increased mean arterial pressure is the effect of epinephrine. But if you do give alpha blocker, then the beta 2 is unopposed vasodilation. That lead to hypotension. Instead of raised mean arterial pressure, suddenly there will be a fall of the blood pressure if you add an alpha blocker to epinephrine. But that is not happening here. Phenoxybenzamine, when you have added, there is no development of hypotension. So that is the reason it is unlikely to be epinephrine, but it is more likely to be norepinephrine. Norepinephrine is what you need to conclude. A chemotherapeutic drug complexes with iron and oxygen. It promotes DNA strand breaks. Its main side effect is pulmonary toxicity, including pneumonitis and fibrosis. What is the phase of the cell cycle is this working? So first of all, after all the description, it complexes with iron, it promotes DNA breakage of the strands, it leads to pulmonary fibrosis. That all is pointing towards one drug, that is bleomycin. So bleomycin acts on the G2 phase of the cell cycle. It is cell cycle specific is what you have to emphatically remember. Which a drug can effectively inhibit the steroidogenesis in a lot of tissues. Ketoconazole is known to decrease the synthesis by inhibiting the cytochrome P450, which is required for the steroidogenesis, is what you should remember. Hemorrhagic cystitis is the important adverse effect of cyclophosphamide that lead to bladder irritation, hematuria, etc., etc. So acrolein is a product formed by the cyclophosphamide, and that is responsible. So we give Mesna, which is the antidote to detoxify this acrolein and protect against hemorrhagic cystitis. What is the drug which is used in the management of acute coronary syndrome like unstable angina? Apiximab. Apiximab is an antibody based drug that targets glycoprotein 2B3A receptors and decrease the platelet aggregation by preventing the cross-linking is what you have to remember. Now, doc. What is an adverse effect caused by an immunosuppressant drug whose mechanism of action is to bind to the cyclophilin and inhibit the action of calcineurin? Very good point, Pradeep Reddy. Glangeman's thrombocytopenia also is 2B3A receptor level problem. Same thing is done by apixaban. Very important. You should know how to differentiate von Willebrand factor from Glangeman's thrombocytopenia, from Bernard-Soulier syndrome. You should know the differences between the three. Many times we discuss this topic, doctor. So how will you get an advantage with all these sessions? Live broadcasted sessions is, these sessions should precipitate what are the areas that I have to improve. So you need to go back to onlinembbs.com. Here you have high yield topics. Every topic 30 to 40 points, quick revision. You have 30,000 hot MCQs, revision, video lectures, PowerPoints, everything. You have the mock tests available, full scale grant tests. Almost 200 full-scale grant tests are available. Almost a huge question bank along with discussions. Then you have every year-wise, right from first year of medical school only, you can start your preparation for all the licensing exams. Year-wise, you have it available. And all these lectures that we are now discussing will go into this USMLE Step 1. And also, every Sunday, morning 9:30 to 5:30 p.m., we have a live broadcast. After this COVID lockdown is over, we are going to have face-to-face class, which is going to get live broadcasted on the YouTube also, right? Medicine, surgery, gynocs, orthopedics, pediatrics, we do the revision. So there is no need of looking anywhere, doctor. You have everything available in the onlinembbs.com. We like to welcome you to subscribe and also promote this channel, www.onlinembbs.com, in all your WhatsApp study groups, classmates groups, and social media groups, because our students are our best brand ambassadors. So, inhibition of the action of the calcineurin is the typical nature of which immunosuppressant and what is the adverse effect of it. So we are talking here about cyclosporin. Cyclosporin inhibits cyclophilin and calcineurin. It binds with cyclophilin and inhibits calcineurin. If the calcineurin is inhibited, the transcription of the various T cell factors like interleukin 2, interleukin 3, interferon, gamma, they're all inhibited. That's how immunosuppression is achieved. But what are the problems with cyclosporin? Nephrotoxicity, gingival hyperplasia, hyperglycemia, hypertension, hirsutism, etc., etc. So what is the drug of choice for iron poisoning? Desferoxamine is the one which is being used, which chelates with the iron and used as an antidote of the iron poisoning. Then dimercaprol is used in lead, arsenic, mercury. Penicillamine, copper poisoning. Sucralfate is the one which is preferred for treating lead poisoning in the case of the kids, is what you should appreciate. Chronic lead poisoning, Chronic lead poisoning presents with auditory and visual loss. Sorry, with not auditory and visual loss. Accumulation of aminolevulanate and inhibition of the heme synthesis. So, inhibition of heme synthesis and accumulation of gamma aminolevulanate in the plasma is what you see with lead poisoning. Then arsenic poisoning, garlic breath, skin pigmentation. Organic mercury, yes, mercury poisoning. Organic mercury poisoning lead to auditory and visual loss and loosening of the teeth. And inhaled mercury can lead to interstitial pneumonitis and neurological effects. That's what you have to emphatically remember. Almost 2 hours we have spent a marathon session, doctor. Thank you all for joining the session and wish to see you all subscribing to the onlineMBBS.com. Please call our helpline 900-868-356. So, what is our plan? Anatomy, physiology, biochemistry, microbiology, pharmacology, pathology, behavioral science. 1, 2, 3, 4, 5, 6, 7. These are the subjects for the USMLE Step 1, which are clinical Binet-based, image-based questions, which are also the questions in any other licensing exam. We are going to do on average around 500 USMLE styled MCQs in each of these subjects, around 3,500 MCQs in next 150 to 200 hours, which gives you a thorough revision of these basic sciences, which is the key factor for getting successful in the exam. The next 21 days of lockdown, let us all work together. Morning, evening, we will try to have 2 sessions. And tomorrow we will start with a question bank of pathology, right? Pathology questions. Thank you very much, and please do join the session every day. Good night.